Hello everyone, this is Cameron Popal. I'm one of the urology registrars working in the NHS and got a national training number recently. This is an emergency scenario for the ST3 urology preparation, and the question is that there's a 12-year-old boy with 2 hours history of acute severe left-sided testicular pain with nausea and vomiting. How would you manage or assess this patient? And so the way I answered it is, until proven otherwise, I will treat this case as a testicular torsion, and I would prioritize to see this immediately and ask the A&E doctor to keep the patient nil by mouth and do a urine dip. I would then take a focus history and perform a clinical examination. My history would include from parents or the child about the onset, duration and progression of pain, whether this was a sudden or gradual onset, whether there's a history of trauma or urinary tract infection symptoms, any previous history of testicular pain which was similar to this, any previous surgical history such as orchidopexy, and then I would examine the patient in the presence of a chaperone and guardian or a parent, examine his abdomen for any inguinal scars or abdominal tenderness, and then examine his testes looking for any kinds of clinical signs of torsion, which include, and you can say first standing and then lying down. Again, in clinical practice, you don't always examine them standing up. I examine them lying down, and it's because patients, for children, sometimes I ask them to walk and jump on the bed. It's a good sign of telling there's torsion. But for the answer, I think maybe just say first standing up and lying down. There's no harm in saying it. And then the things that you're looking for is an acutely tender, swollen testes, firm testes, horizontal lie, high riding, whether I can reach above the testes, thickened cord, absent cremasteric reflex, erythema of the scrotum, or mild fever, which are late signs. What are your differential diagnoses? Number 1, testicular torsion. Number 2, torsion of high dated of Morgagni, epididymoarchitis, strangulated inguinal hernia, traumatic hematocele, or testicular rupture. What is the French sign? So French sign, so basically you lift the testes, it reduces the pain in epididymitis but does not reduce it in testicular torsion, but this is a notoriously unreliable test. What are the investigations required? So there's no investigations required other than a simple bedside urine dip and bloods, if that doesn't delay the procedure. The testicular torsion is a clinical diagnosis. And then the question asking about the merit of Doppler ultrasound in testicular pain. So a demonstration of blood flow to the testes is reassuring, but false negative rates of 11 to 25% remain unacceptable. So there's a lot of talk about ultrasound testes, and in America, for example, everyone has an ultrasound of the testes prior to their torsion surgery, but it's a private setup and you can get it very easily. It doesn't delay things, and apparently it's something that helps guides things. But in the NHS, I think this is a very safe answer, where you say there's a false negative rate of 11 to 25%. So if you were clinically concerned, we should take the patient to explore him, and henceforth I would only do an ultrasound if I sort of was sure that this was not torsion. If you're unsure and you're thinking that this might be, you just take and explore him. First because of delays, second because of false negative rates, and you don't want to risk it. Then examination findings. There's a swollen, high riding, tender testes with negative cremasteric reflex, and the urine dip is negative. How will you proceed? So say, I'm highly suspicious of testicular torsion. I will gently break the bad news to the patient and parents and inform them the patient needs an urgent scrotal exploration plus minus bilateral orchidectomy plus minus left orchidectomy, and mark the patient. And fill consent form 2 with the parent signatures and patients if he wants to sign. I would keep the patient nil by mouth and ask the peds nurse to prepare the patient and find a best bed post-operatively. I would then inform my consultant, CPOD, theatre coordinator, on-call anesthetist to see the patient, go to theatres and team brief for the case. So small points, just remember the steps about the patient, the people who you will inform, parents, theatres, on-call consultant, anesthetist, brief, everything. What consent form will you use? So consent form 2 should be used. So what consent form will you use? Consent form 2 should be used. Children under 16 years who can have parental or guardian. Children under 16 years should have parental or guardian consent. Technically, child doesn't have to sign, but is encouraged to do so. Anyone above 16 years of age we can use a consent form 1. So fine, you go for a brief or to book the case in CPOD. There's a laparotomy going on, which will minimum take another 2 hours. How will you proceed? So explain the urgency, request theatre coordinator to open another theatre, alternatively during the daytime hours stop an elective list to do it. Lastly, we can look for sister hospitals where it can be done, but the transfer needs to happen in a time critical manner if none of the above is possible. So patient is not starved. CT1 anesthetist wants to wait for 4 hours. Again, this will need rapid sequence induction with intubation, and explain the nature and urgency of the matter, and recommend he calls his senior if he is not comfortable anesthetizing this patient. But you have to say it very kindly, because you can't be arrogant about it in the interview. You just have to say it nicely. I will explain the urgency of the matter and suggest that this will need rapid sequence induction with intubation, and recommend if he's not comfortable with this general to anesthetize the child, he may want to contact his seniors. So just say it politely, not in an arrogant manner. So presentation at 6 hours, how will you proceed? I would still proceed with scrotal exploration. Although probability of viable testes diminishes beyond 4 hours, some testes can survive up to 12 hours depending upon the degree of torsion. I will let the patient and parents know about the high risk of orchidectomy. How will you consent the patient? You can find the consent yourselves. What are the steps of the procedure? Again, we can go over it in the clinical skills bit. And why not fix the untorted testes? Obviously, because of blood testes barrier breach, and tunica breach leads to development of anti-sperm antibodies, which can cause infertility. Well, there's a theoretical risk of that. If the testes is torted, what will you do? Okay, so detort the testes, bilateral orchidopexy. If testes not viable, even with Worm's line-soaked gauze, wrapping in 100% oxygen and no bleeding on tunica albuginea stab, we would consider an orchidectomy and fix the other side with 3-point fixation. I think we'll go over this in the clinical scenario, clinical skills again separately. So I'm not going to go in too much detail. So if the testes is dusky, what will you do? So Worm saline, 100% oxygen, tunica albuginea stab to look for bleeding. What if the testes is dead? So orchidectomy if no bleeding. Post-op explanation, and see the patient in clinic for review of future prosthesis when the patient has grown up. That's the end of the testicular torsion scenario. We'll see you with the next scenario, which is renal trauma. And hope you're benefiting and enjoying from these videos, and hope you all get a national training number.